Hi, I'm Manmeet Ahluwalia. I'm a medical oncologist and the director of the Brain Metastases Research Program at the Cleveland Clinic. I'm here at ASCo 2016, where we presented our research on impact of EGFR and ALK mutations on outcomes of non-small cell patients with brain metastases. This was presented in our oral abstract sessions in the CNS track. So background, patients with non-small cell lung cancer often have brain metastases. 10% with non-small cell lung cancer in the United States, Caucasian patients, and 35% in East Asia harbor EGFR mutations. 5% of non-small cell lung cancer patients have ALK rearrangements. Our work and those of others have shown that patients with EGFR positive brain metastases have improved outcomes in the ballpark of 20 months as compared to those who have the wild type. Those who have ALK mutations actually even have a better outcomes close to 4 years. Graded prognostic assessment tool for non-small cell lung cancer brain metastases, work by Paul Sperduto and colleagues, have shown that a number of factors take into account how patients will do. So the critical factors that have been previously shown to have prognostic implication include age, performance status in terms of Karnofsky performance status, extracranial metastases, and number of brain metastases. The dogma has been that the modality of treatment is often based on the number of brain metastases. So patients who have 1 brain metastases generally do better. Patients who have 2 to 3 brain metastases do less as well when compared to patients who have 1 metastases. And someone with greater than 3 metastases means someone who has 4 or more metastases generally forms in the worst outcome group. So based on this, with the new molecular profiling, we wanted to look at how our patients with mutational status were doing. So we looked at an IRB approved Cleveland Clinic database. Primary endpoints were overall survival from diagnosis of brain metastases. Secondary endpoints included progression-free survival. We used the Cox proportional hazard models to do our statistical analysis. This is a slide showing the patient characteristics, which was fairly well balanced in both the arms in terms of the known prognostic factors that include age, performance status, number of brain metastases, and extracranial metastases. Patients with mutational positive disease included 91 patients in our cohort, and those who were the wild type constituted 257 patients. They were treated in the same era and very similar modalities. This slide highlights how they were treated. The treatment with stereotactic radiosurgery and surgery, or treatments with whole brain radiation and surgery, was fairly well balanced in both the arms. The patients who had mutational status appropriately received a higher amount of targeted therapies because they are drugs which have better outcomes in this patient population. So when you look at overall survival, the graphs on the left are patients who had a mutation positive disease, and you can see patients with 1 brain metastases as compared to 2 to 3 or greater than 3, there was no difference in overall survival. However, those who had the wild type disease, still based on the previous prognostic models, patients who had 1 brain metastases did better as compared to 2 to 3 or more than 3. There was no difference between those who had 2 to 3 as compared to more than 3 brain metastases. So what we did was we further developed a modeling, because what we found out that at least in the wild type group, there was an association between the extracranial metastases and the number of brain metastases. So we did 2 models, multivariable analysis without the ECM, and what we found out was in the mutation positive group, there was still no difference statistically between whether you had 1 brain mets, 2 to 3 brain mets, or more than 3 brain mets. And in the wild type, this difference was weaker as compared to before. When we looked at overall survival, you can see no difference between the survival based on 1, 2 to 3, or more than 3. However, in the wild type group, there is a difference. Those who have 1 brain mets do better as compared to those who have 2 to 3, as compared to those who have more than 3. Then we further looked at what this model holds when we include the extracranial metastases, and same thing holds true. No difference when you have mutation positive disease based on the number of brain metastases, but there is a difference when you take a look into the wild type. So what we conclude based on our observation that this Perduto GPA model, based on the number of brain metastases, holds true only for the wild-type non-small cell lung cancer with brain metastases. However, based on the recent efforts on molecular profiling based on tumor biology, the number of brain metastases in mutation-positive disease does not impact the overall survival. This is based on the biology of the disease when treated with stereotactic radiosurgery, but also in this era of targeted therapy, the number of brain metastases has become a moving target. We are in this era of precision medicine where we need to take into account every patient and individualize care. We intend to validate our results in an independent cohort. We are designing the next generation of trials based on the results of our presentation. Thank you so much.